Hi, and welcome to Ask Me Anything for today, the 11th of September, 2020. We have a question from Lisa. Lisa says, "Hi Raf, I hope you're well. Thank you so much for doing these AMAs. They're extremely helpful. Glad you find them helpful, Lisa, and nice to hear from you. I'm wondering if you've ever had a person who's currently receiving treatment for cancer participate in a Matwork Pilates class you're teaching. Assuming a doctor has given them the green light and cleared them to add light exercise like Pilates into their routine, and the teacher keeping in mind that strength balance may be less than before cancer treatments, how would you go about creating a class for them? What are some of the considerations a Pilates teacher should keep in mind for this client? And with a Cert 4, are we allowed to teach people who are currently undergoing treatments? Any exercises you would likely avoid or any other tips? Thanks so much." Well, Lisa, people with cancer are recommended to engage in exercise during and after cancer treatment, and exercise has been shown to be safe and beneficial for cancer survivors, and that includes people who are currently undergoing treatment. Cancer is not one disease. It's a group of around 200 related diseases, and so there are different specific modifications that you might need to make in relation to different types of cancers. For example, somebody with breast cancer may undergo radiotherapy or a mastectomy surgery to their chest area, and sometimes they have to take out part of the pectoralis major muscle if they do a mastectomy and the cancer's infiltrated the pec muscle. Sometimes they take out the lymph nodes under the armpit if the cancer has spread to the lymph nodes. And even if they don't take out any of those things, just the radio frequency treatment essentially cooks the tissue of the muscles and skin and ligaments and tendons and fascia in there, and makes it more stiff. And you might possibly combine that with a surgical scar and removal of part of the muscle, and what you get is really reduced range of motion. And if that's the case, then you're going to have to work on gradually stretching that out and increasing range of motion, building strength back up in the pec muscle. And if the lymph nodes have been taken out, lymph is a system, it's part of your circulatory system that essentially returns fluid to the blood system that leaks out, which is fluid leaks out of our capillaries, our blood vessels, as a normal part of circulation, and is returned to, washes past our cells and nourishes them, and then is returned to the heart via the lymph system. And so think of lymph as essentially, it's kind of similar to veins in that veins return blood to the heart, whereas the lymph system returns lymph to the heart, which is essentially all of the liquid parts of blood without the blood cells. If the lymph system has been compromised, like if there's been removal of part of the lymph system, then the arm can get really swollen because the lymph system that usually returns that fluid back up to the main, to the torso and the heart has been removed. So when people exercise, blood gets pumped into the arm, fluid leaks out of the vessels like normal, but it doesn't get sucked up by the lymph system because there's no lymph system. So the arm can swell up like a balloon. So people, for instance, it's called lymphedema. Edema is swelling. People who have lymphedema as a result of their lymph nodes being taken out should wear a compression sleeve when they exercise, and that's just essentially a crepe bandage like you buy from the chemist when you've got a sore elbow or something. And they'll probably be given one by their treating medical professional. But they should wear that if they've had their lymph nodes taken out. People who've had mastectomies may be really concerned about, feel kind of embarrassed about their appearance. They, they may not want to be touched around their upper body. So those are kind of some specific considerations for breast cancer. And then for other types of cancer, there are also specific recommendations. For example, with bone cancers, then where the cancer has infiltrated the bone and in any part of the body, the bone becomes more brittle and is more weaker and easy. It can fracture more easily. So people with bone cancer you need to avoid impact and if it's in the spine, flexion under load. So basically, as if they had osteoporosis, you treat them the same as if they had osteoporosis. And so that's a couple of examples of different specific considerations you'd have for different types of cancers. And then there are general considerations that are common for all cancers, really. And for just about every cancer, the number one symptom is fatigue. So people who are undergoing treatment for cancer, the treatment causes fatigue, the disease itself causes fatigue. So people with cancer generally have fatigue. And so you need to work with their energy levels on the day. Some days are good days, they can do more. Some days are bad days, they can't do as much. You just have to work with that. People who are undergoing chemotherapy or other immune suppressant therapy have a much higher risk of infection. So it's a good idea for them to have their own equipment and not to share equipment with people, to make sure that the equipment is sanitized before and after they use it. And I'm not talking about a drop of tea tree oil. I'm talking about actual hospital grade disinfectant, and also that you observe good hand hygiene, which I think in these days of COVID we're all hopefully pretty good at. So I'm talking about 20 seconds while you sing happy birthday, doing all of the different World Health Organization hand hygiene procedures before you touch that client and after you touch other clients before you touch that client. So those are kind of the general guidelines. Now, if you're going to be working with people who have chronic medical conditions, you should absolutely get yourself a copy of this book. ACSM, the American College of Sports Medicine's Guidelines for Exercise Testing and Prescription, 10th edition. That's the current edition, published in 2018. And it's available on Amazon or Booktopia or Fishpond, any place. The hard copy is about $45. It's an absolute wealth of information. It's got a whole chapter on cancer, and it's got a table with all of the specific recommendations for different types of cancer and also all the general recommendations. So you really, really should buy yourself a copy of that. And you can I've actually found a PDF copy that I found online, which was only like $17 Australian. So you really should absolutely get a copy of that. Can you be working with someone with cancer? Absolutely. Exercise is recommended for people with cancer. You just need to check in with them, find out how they're feeling each day, whether they're on immune suppressant medication, and if they have any, depending on if they've had a surgery or radiotherapy, the part of their body where they've had surgery or radiotherapy may be stiff, sore, weak, etc. So you just, if they had a stiff, sore or weak body part, as per normal, you would just gradually stretch and strengthen that up. With the caveat that obviously a recent surgery that is still healing, within the tissue healing time, you would not stretch it or strengthen it. And if anyone comes to you post-surgery, they should have some kind of leaflet from their doctor. Usually the doctor, when you have a surgery, they give you a little green photostated piece of paper that says, the first 7 days do this, the second 7 days do that, the next 4 weeks do this, and it tells you kind of when you can start exercise again. And if in doubt, ask the person's permission to email their doctor and ask them for their doctor's name and the practice where they practice at, and then just send it, ring up the practice, say, hey, I want to email the doctor, what's the email I send it to? And then email the doctor, CC the client, so everyone knows that everybody's included. Just say, hey, client name, gave me permission to contact you as she's coming to my exercise class or he's coming to my exercise class. We're doing Pilates. I just wanted to check in with you vis-a-vis, do you have any particular exercise recommendations, contraindications, etc. But basically, if you buy that book and you read the chapter on cancer, you will find a wealth of information and specific advice there. So that is what I would suggest to you. And people with cancer, Lisa, need to exercise just like everybody else. Exercise has all of the same benefits for people with cancer, as in improves mood, improves energy, improves cardiorespiratory fitness, all of those same benefits that it has for people who don't have cancer. Plus, for most types of cancer, it increases life expectancy in people. So it certainly can't cure cancer, but it generally enhances the quantity and quality of life for people with cancer. So exercise is fantastic, and they should absolutely be doing it with you. All right, I hope that helps. And go by the ACSM's guidelines and get in touch with the person's doctor with their permission. Stephen has a question. Stephen says, hi Raf, just wondering about heart rate in relation to weight. When running, I notice I'm sitting at 170 beats per minute, others at similar pace at 155 beats per minute. Is heart rate more closely related to lung capacity or weight? Well, Stephen, that is a great question. And so basically, when you run or do any other form of aerobic exercise, your muscles require more oxygen to burn more glucose to produce more energy. And so the factors involved in getting more oxygen to your muscles are your breathing needs to increase, so you need to take in more air. You need to store that, transfer the oxygen from the air into your blood, into the hemoglobin in your blood, and you need to store that oxygen in the hemoglobin. And then you need to pump that blood around your body to your cells with your heart, and get it there fast enough so you get enough oxygen delivered in a short space of time for those muscles. And then you need to the muscles need to be able to absorb the oxygen and use it to burn carbohydrate and break down glycogen and release energy in that process. So all of those steps, each one of them is critical, and they're all interrelated. So, for example, if you have for some reason, a reduced capacity to, a reduced lung capacity, well, you get less air in per minute. So therefore, you can compensate though by increasing other aspects. So your heart could beat faster to pump the air that is in your system around quicker and get more of it to your cells more quickly. Or if you have for some reason a reduced stroke volume, so your heart is, it from its full state to its contracted state, the amount of blood that it pumps, each pump is less than average. Well, you can pump your heart faster to compensate for that. If you have reduced circulatory system volume, blood volume, circulating blood volume is the phrase I'm looking for. So less blood, basically, if you're dehydrated. you have less blood, your heart has to pump harder, and you will breathe more to oxygenate the blood that you do have and get it around to your system. So there are multiple other factors involved as well. If you had low hemoglobin because you're iron deficient, you could compensate by breathing more heavily and pumping your heart harder. So all of those things are, multiple kind of overlapping systems that are kind of semi-redundant that enable you to transport oxygen to your cells fast enough that your muscles can use it to contract. And in each of us, we all have some different combination of those factors. So, someone might have a slightly bigger heart, like a bigger stroke volume, but less capacity for the heart to beat fast. Someone else might have a greater lung capacity, but a smaller heart maximum heart rate. So the heart rate itself is not really an indicator of anything in particular. And probably the best measure for you, or for all of us, unless you're in an exercise science lab, probably the best measure is rating of perceived exertion, or RPE. So basically, on a scale of 1 to 10, 1 being you're lying on the couch watching Netflix, and 10 being you are sprinting up a sand dune in the Sahara with a tyre tied around your waist. 10 is your maximum exertion where you are like totally maxed out. Your RPE, your subjective experience of how hard you're working, has been shown by quite a bit of research to be a very reliable indicator and pretty accurate indicator of how hard your whole system is working. So your heart rate might be much higher than the people who are running with you at the same speed, but your whole system as a whole might be working no harder than their system. It might just be that when in balance, you have a higher maximum heart rate because they have a higher something else or a lower something else, and that's just the way that your system works. Like I know myself, when I'm running, if I'm cruising along, like if I'm at 170 BPM, I'm just about to have a heart attack. Like my heart can't go that fast. My heart can get to like 165, 168. That is a flat out sprint for me. Whereas I can cruise all day on 145 running at like 13.5 kilometres per hour. But that doesn't mean I've got like 40 beats or 50 beats per minute in reserve. That's like, so it may just be that you've got this really awesome attribute of a higher maximum heart rate, and that your cruising velocity is 170 beats per minute and you can get up to 200 beats per minute. Which is awesome. So I wouldn't be at all concerned about it. And I would just suggest use your RPE, your rating of perceived exertion, from 1 to 10 as a really good guide, and ask your friend who's running at 155 beats per minute what their RPE is. And, that's an indicator of how hard your system's working. And that's probably an indicator, that's a really good indicator, probably the best indicator available of how hard you're working relative to your current fitness level. So that'll be the RPE. There's a really strong relationship between RPE at a given pace and VO2 max. So, I hope that helps. Don't bother about heart rate too much compared to other people. It is a good measure within your own effort. Like at 170, how hard that is for you, 140, how hard that is for you, etc. But don't really compare it to others. Hope that helps. Priscilla says, "Hi, Raf. My question is, with the completion of the course, that's the Certificate 4 in Pilates, can we work with people with disabilities? I have a family who have NDIS plans and have questions. NDIS is the National Disability Insurance Scheme in Australia, and have questions about working with them as they have physiotherapy. What path would I have to go down? Is there anything extra that I would need to do? Looking forward to your response. Thank you. Take care. I'm thoroughly enjoying the course so far." Well, glad to hear it, Priscilla. Well, I have to say, Priscilla, this is outside my area of expertise, and I did have a little dig, but I have to admit that when I start reading the government websites about NDIS, my eyes kind of go cross-eyed, and I get confused very quickly. I'm an exercise physiologist. I'm eligible to work with NDIS clients, and I've made a conscious decision not to, simply because it confuses the hell out of me, the whole rules around it. So I'm very sorry I can't help you. I can't give you any specific advice with that. I can just say that my broad understanding is that NDIS, the National Disability Insurance Scheme, is a scheme where basically for people who have a disability, that the government gives them a budget, a certain amount of money, and then that the person with the disability, the client, gets to choose where they spend it. So they can spend some of it on home help, and some of it on getting shopping delivered, and some of it on a physiotherapist, and or they could spend it all on getting massages. There's lots of things they could spend it on, and they get to choose basically. Now, whether you're eligible to be one of the providers for that, I can't tell you. I'm sorry. So I'm going to refer you to the NDIS website, and you're going to have to go down that rabbit hole and spend some time there yourself. I'm sorry I can't help you with that one. Leia says about sciatica. I have a very big question in mind. And I've tried two different ways when people come to see me with sciatica. The first way is I move them in a gentle way and not put weight on the painful leg. And the second one is move it and load it. All right, so firstly, just as an aside, sciatica is essentially leg pain that is associated with back pain. So it's basically leg pain that is caused by some kind of irritation to the nerves that come out of the low back and go down the leg. And the name of the major nerve that goes down the leg is the sciatic nerve. And so if that nerve is kind of irritated somewhere in the low back, you can have symptoms of pain in the leg, even though the cause of the problem is most likely in the low back. All right, so Leia's question about sciatica is she has two different approaches. One is to move it gently and not load it. The other one is to move it and load it. Sometimes people get better with one and sometimes the opposite. It's really tricky. I don't know how to help them. I actually tried two opposite ways, and sometimes it works and sometimes not. Different people who feel better when they isolate versus move. So basically, it's not the same person that sometimes moving helps and sometimes not moving helps. But sometimes some people feel better when they move the painful bit, and other people feel better when they don't move the painful bit. And so the question is basically, how do you know which to do? Should you move or should you not move? All right, so I did some research on this, and here's what I came up with. So there's good news and bad news. Well, the bad news is that, actually there's good news and bad news and good news. So we'll start with the good news. The good news is that the prognosis, the natural history of sciatica, what's likely to happen if it's left untreated. So if you have raging leg pain that goes into your bum or your back of your thigh or down the side of your calf and into your foot, any combination of those body parts, if you have that with or without back pain, the prognosis, if left alone, it's very likely to go away within a year. And that is for the majority of people. And actually, people with worse pain at baseline are more likely to recover if the sciatica is caused by a disc bulge or a disc prolapse or something like that. So people with a worse disc prolapse are more likely to recover. So that's the good news. So really, if it's fairly recent onset sciatica, the good news is it's probably going to go away all by itself within about a year. The bad news is, through quite a number of systematic reviews, exercise has been shown to be marginally effective for sciatica. It's not been shown to have great benefit. There are lots of benefits to exercise that are not specific to sciatica. So exercise certainly can help people with their mood and their optimism and their general health and quality of life and their functional capacity, their ability to get around and do stuff. But it hasn't been shown to be terribly effective for pain related to sciatica. So that's the bad news. Then there's the good news. The good news is I found a really fantastic little guideline summary from NICE, which is the National Institute of... What's NICE stand for? I looked it up before and then I forgot what it stood for. National Institute for Health and Care Excellence in the UK. So it's the United Kingdom's nationalised health service. The NICE guidelines for managing low back pain and sciatica. And they have not only a set of scholarly printed guidelines, I've got this marvellous little infographic. So I've shared that with you here. And this is the current NICE guidelines from 2017, managing low back pain and sciatica. So here's the decision tree. So firstly, and Leia, I know that you already know this, but this is just what the guidelines say. Firstly, exclude specific causes of low back pain, for example, cancer, infection, trauma, inflammatory disease, or cauda equina. So that's in what we learn in the Cert 4 and the diploma as essentially screening for red flags. So we first screen for red flags, which I'm sure you've done, and that's only if someone has new onset sciatica. So if someone comes to you and they've had sciatica for some period of time, previously, then you don't need, and they've already seen another healthcare provider about it, you don't need to screen them for red flags. But if it's new onset, you do need to screen them. Do not image. Only consider imaging in specialist care and if it's likely to alter management, which in this case it's not. Assess the likely recovery outcomes. Now, what they say here is that the indicators of poor outcomes are fear and pain avoidance, low mood, job dissatisfaction, and ongoing litigation. And I found a couple of systematic reviews from the last couple of years that also found that poor expectation of outcome is a very strong predictor of outcome. And all of those are in fact psychosocial factors. So if they have more of those indicators of poor outcome, they should probably receive more intensive interventions, which is combined physical and psychological interventions. So they should probably be referred to somebody who can coordinate a multidisciplinary approach if they have a lot of those indicators of poor outcome. If they don't have a lot of those indicators of poor outcome, then they should go into group exercise. And what's recommended is some combination of yoga, Pilates, Tai Chi, cycling, group fitness, just general movement, basically, stretching and strengthening. There are no specific recommendations for moving them forwards or backwards or isolating or anything like that. If that doesn't help, which sometimes it doesn't, or even fairly frequently it doesn't, the management options are neuropathic pain medication. So these are things like gabapentin and epidural steroid injections. So just injections into the back of steroids or local anesthetic, and spinal decompression surgery. So all of those things have reasonably good support in the literature that they do in fact improve outcomes more than exercise, even when it's combined with manual therapy. You can add in manual therapy and psychological therapy, but they should only be adjuncts. to exercise. So you shouldn't have the manual therapy or psychological therapy as the main treatment modality, but they can improve outcomes when added to exercise. And paracetamol shouldn't be used, so Panadol or acetaminophen as it's called in the US. NSAIDs, non-steroidal anti-inflammatories, so things like ibuprofen, which in Australia has a brand name of Nurofen, or things like Voltaren, they're non-steroidal anti-inflammatories, and also weak opioids. So, of course, as Pilates instructors, we're not giving people injections or prescribing medication, but this is just so you know. These are the guidelines, and do not offer acupuncture because it doesn't help. So those are the NICE guidelines, and I will link to those in the description of this video. Finally, I just want to talk through a plausible sort of anatomical explanation of why some people get better, get temporary relief from sciatica with gentle movement, and some people don't. Now, this is not based on any study or science. It's just me kind of reasoning from first principles about potential mechanisms for your experience. There are many other potential mechanisms, like, for example, maybe it's not related to what you did. Maybe it's related to that person's expectations about what you did. If they expect moving to make it better, moving is more likely to make it better. If they expect working with you to make it better, working with you is more likely to make it better. If you had a more positive interaction, if you had a better therapeutic alliance with that person, and so whether you got them to move the body part or keep it still might have just been kind of incidental to whatever benefit they got from the interaction. So there are many, many possible reasons, called contextual effects, for why someone might feel better after you gave them an exercise that have nothing to do with which exercise you gave them or any sort of physiological direct effect of that exercise. However, there are also a couple of explanations that do involve mechanisms of the exercise. So let's talk about one of those. All right, so if we think about your vertebral bodies, discs, here's your spinal canal with your spinal nerves in it, and this spinal nerve exits through this neural foramen here and then splits off into different nerve tracts, and we'll call that the sciatic nerve. And then if we draw in the rest of your vertebrae, this would be the spinous processes, etc. And that might be your L3 your vertebra, your L4 vertebra, and your L5 vertebra. And this would then be your sacrum down here, S1. All right, so that is the kind of a side view. And so this is your spinal cord, and that is your sciatic nerve, which is just a branch that comes off the spinal cord and then goes down your leg. And so there are two possible mechanisms. Now, like I said, there are many other mechanisms. These are just two that kind of came to my mind when I was thinking about this. So the first possible mechanism is a disc bulge. Let's create a disc bulge here. All right, so if we create a disc bulge that bulges out here, okay, and kind of presses on the sciatic nerve where it exits out from the spinal canal, and it presses on the sciatic nerve. And so basically in that situation, anytime you move, know, if you bend your back forwards, okay, you bend forwards, or if you bend backwards, you are going to cause that nerve to essentially get dragged across that disc bulge like a violin bow across a violin string, and you're going to kind of scrape that nerve along the disc bulge, and that's going to cause some kind of irritation and potentially symptoms in the leg and potentially symptoms in the back as well. So that is, if the cause was a disc bulge, there are many other potential things that could cause it, but if the cause was a disc bulge and if the disc bulge was pressing on the nerve in a particular spot such that when you bend that spot, the nerve is kind of scraped across the disc bulge, well, that could explain why moving hurts and keeping still doesn't hurt. So that's one possible explanation. And now if we get rid of our disc bulge and think about a different possible cause. So let's think about, in fact, let's get rid of this altogether and create as like a slightly different view. So this is the inside of the spinal canal, and here is the neural foramen. Now, I know this isn't anatomically accurate, but it's about as good as my powers of drawing allow me to do. So on this side is the vertebral body, and on this side is the next vertebral body, and here's the spinous process. And if we look from the side, this would just be a solid mass, like right across here would all be just solid. But of course, I've cut that away for you so we can see into the spinal canal. So, all right, let's get rid of this bit here because that's kind of silly, but this looks pretty good. I like that. So here's our spinal canal, and here's our nerve tract. Okay. Our nerve tract is composed of a tract is just a whole bunch of nerves that are kind of bundled together, and then a smaller nerve tract comes out here, and this one continues on down. Now, in fact, the nerves don't come out exactly like that. What actually happens is these nerves here end about there, and then they join to new nerves. These nerves here, these are the tails of nerves that are where the nerve cell bodies are in your brain. And these are the long tails that reach down. And they synapse here with a new nerve. So there's a new nerve body here, and a new nerve body here, and a new nerve body here of all these different nerves. And then these tails of these nerves go out down your leg to different places. So these are basically nerve bodies. And so this, where the nerve comes out from your back is called a nerve root. And it's a bit bigger. It's a bit bigger than the general body of the nerve. It's kind of a bulge, just like I've drawn it here. I think that's the best part of my whole drawing. So there's a bit of a bulge. There's the nerve root, which is simply composed of all of the cell bodies of those neurons, those nerve cells, that form that nerve tract. All of the cell bodies are in that nerve root. And then the tail, each one of these has a little tail that is an individual nerve fibre. An individual nerve fibre. And the tails are much narrower than the heads, than the cell bodies. So the nerve tract, is much thinner than the nerve root. All right. And of course, this is your spinal cord. Now, before we said imagine a disc bulge, okay? So what I'm going to posit now is an alternative possibility. So imagine there is no disc bulge, but let me just wave a little magic wand, and somehow create some kind of irritation inside your spinal canal, like some kind of inflammation, something rubs, or there's an infection, or there's some minor irritation in there. Sometimes you get an irritated finger, sometimes you get an irritated spinal canal. It's just like one of those things. Who knows why it happens? So allow me to create some little bit of inflammation in there. Well, what happens when something gets inflamed is you have more fluid is attracted to that area, is one of the things that happens. And in your finger, when you get an inflamed finger, that's what happens is then your finger swells, gets bigger. However, this is a hollow bone tube. So this is a bone tube. Your spinal nerves live within a bone tube inside the back of your vertebrae, and that is called your spinal canal. And that space is your spinal canal. It's a bone tube, so it's not stretchable. And if you squish more fluid in there, okay, if we put more fluid in there and we fill that up with more like fluid, like cerebrospinal fluid plus a bit of inflammation fluid, the pressure increases. Okay, it's like if we forced more lemonade into the lemonade bottle before we jammed the lid shut. It's got more pressure in there. Now that pressure can cause the nerve to become irritated. It can cause the nerve to become irritated. Just the pressure from the increased fluid that is just a result of just a normal low-grade inflammation. So in this case, that person now might have pain that they experience as coming from down their leg somewhere, whereas in reality, the nerve is being irritated inside their spinal cord or right at the exit to the spinal cord. So in that case, if you gently move this area, like with, say, a cat stretch or some gentle pelvic curls, some kind of gentle movement, what can happen is that movement will clear the inflammation. It will pump some of that fluid out. Okay, it will reduce the pressure in the spinal canal and thus alleviate that irritation on the nerve, which could well alleviate the symptoms. So there are two possible mechanisms for how sciatica may have a relationship with what's going on in the low back, and a plausible reason, I think, why in some cases keeping it still could help, and in other cases moving it could help. But I really do want to emphasize that probably, based on the research that I looked at and the NICE guidelines, that there probably is very limited benefit from any kind of exercise in relation to sciatica. And probably most of the benefit that your clients are getting from their sciatica, pain relief from their sciatica, from working with you, is to do with contextual effects, so non-specific effects. The feeling more better self-efficacy from doing something for themselves, feeling a strong therapeutic alliance with you, feeling that you care for them, that they trust you, and that you're working, for their best interests. Expectation effects, expecting that they will benefit from doing exercise, therefore they do. Social support of hanging out with other people who are also exercising, maybe also experiencing, physical pain and getting better and working through the trials and tribulations that entails, and everybody's in it together, and that can help. So there are a whole host of other non-specific effects that we could list. It could also just be maybe they didn't get better as a result of anything you did. Maybe they were just on the way up anyway. Like if you look at any if you look at, most people with chronic pain, whether it's in the leg or the back or wherever, there are bad days and there are good days and there are bad days and there are good days. And for most people, it's not exactly regular like that, but it's, goes up and it goes down. And people might have their worst day, and their best day, and their worst day, they might have like a 7 out of 10 pain, and their best day, they might have a 3 out of 10 pain, and most days it's somewhere in between that. Okay. Well, if they come to you and they got a 7 out of 10 pain, it's almost certain that next time you see them, they're going to be better. Right. And that's called regression to the mean. Regression to the mean. And what that says, all that says is when things are at their worst, they are very likely to get better. Okay. And then they might get better the next day, and then they go, oh, it was that magic stretch that Leah did with me. But in reality, it was just, they were just going to get better anyway. So there's probably some combination of all of those things that I've just mentioned, plus a half a dozen or 10 other things. So Leah, I hope that helps. I guess, practical takeaways from that. Don't worry too much, because probably very little you do in the way of exercise is going to have much of a specific effect one way or the other. It's probably more about how you give the exercise, as in your, the conversations that you have, your tone of voice, your eye contact, expectation, care, all of that stuff. And secondly, that if somebody responds well to gentle movement, great, do more gentle movement. And if they respond well to not moving it, but moving their other body parts, great, do that. And I hope that helps. So that is all the questions that we have for this week. There are a couple that I haven't had time to answer, but I will get them to them next week, I promise. And I hope you find these helpful. If you have any questions you'd like to ask me, I'd love to hear from you. Whether you're a current student or a past student of ours at Breathe Education, or whether you've never had any contact with us and all you do is furtively watch these videos, I would love to hear from you. You don't need to be a paying customer for us to have a dialogue here. So if you have questions about anatomy, physiology, biomechanics, Pilates, business, how to set up a video light thingy, I'd love to answer them. If I can't answer them, I'll be honest, just like I was with the NDIS one today. And oftentimes I don't know the answer initially, but I just go and look it up. So you can reach me at Raphael, RAPHAEL .B for Bob, at breathe, breathe.edu.au. And if you send me your question, I will answer it. I hope you have a great week. Hope you're well. Hope your loved ones are well and safe and happy. And I look forward to our next conversation. See ya.